Buenos días a todos. Antes de comenzar, quiero compartir con ustedes unas breves instrucciones sobre el uso de la interpretación simultánea que estará disponible durante este webinar. Las presentaciones se desarrollarán en idioma español, pero se contará con interpretación simultánea al inglés y al portugués durante toda la sesión. Para seleccionar el idioma de su preferencia, dirija hacia el menú inferior de su pantalla y haga clic en el icono con forma de globo terráqueo. Al hacerlo, se desplegarán las opciones de idioma disponibles: español, inglés y portugués. Now I am going to repeat this part in English just in case someone needed. The presentation will be conducted in Spanish, but simultaneous interpretation into English and Portuguese will be available throughout the session. To select your preferred language, go to the bottom menu of your screen and click on the globe icon. Once clicked, the available language options will be displayed: Spanish, English, and Portuguese. Para una mejor calidad del sonido, les recomendamos seleccionar la opción silenciar audio original si eligen escuchar el evento en un idioma distinto al idioma original que está siendo utilizado por parte del panelista. Esto les permitirá disfrutar de una transmisión más clara y fluida. Para dar inicio a nuestro evento, le doy la palabra a Janet Gija, directora ejecutiva de FIFARMA, para que nos dé las palabras de bienvenida.
Muchas gracias, María Paula.
Good morning, Maria Paula. Thank you so much. Kind greetings to everyone who is connecting right now to this webinar that we have organized in the framework of the World Day of Rare Diseases. I'm Janet Gija, Executive Director of FIFARMA, the Latin American Federation of the Pharmaceutical Industry for Research and Development. And today we're meeting with a very clear objective, and it's visualizing the challenges faced by thousands of patients in Latin America to access in a timely manner to diagnosis and treatments that can change and save their lives. And that's what we are here for today. And one of the things that we do the most in FIFARMA is generate evidence, because I do believe, and we are completely convinced at our organization, that when we have a conversation with evidence, the conversation changes and there's new possibilities and paths and opportunities for solution that open up. And one of the studies that we held to generate evidence is our FIFARMA weight indicator. We've generated it for several years already, and it starts giving us data that is very important for our region. Based on this weight indicator, the last one we issued last year, the next one's coming soon, the average in time for an innovative medication to be available in the region is above 5 years, combining the regulatory process and effective access to the health systems. More than 5 years. While a person in the United States or in Europe has the best treatment possible, it takes us 5 more years to be able to have it. And that is not just a number. It's not just a simple number. It's a life. It's a person. It's a family. It's an entire community. And that's also our invitation today. In the case of rare diseases, beyond the weight that gathers several therapeutic areas, the issue, we've had a lot of advances, but the issue is very concerning. Only 70% of orphan medications approved actually reach the patients, compared to 80% that we have for other pathologies. That's why in today's webinar, Oscar Hurtney, IQVIA researcher, will tell us in detail the availability of innovative medications for rare diseases in our region, and we will basically be able to see where we have more challenges in what areas in regulatory and availability, which countries have are doing better than others. And I think this will help us to have this such valuable information. And after Oscar's presentation, we will have a panel that I think will be wonderful. It will be moderated by Carla Baez, Executive Director of AMIF, where we will be having a dialogue from 3 perspectives. And I love this because it's 3 viewpoints that are complementary in this process. And we will have the clinical perspective with Dr. Nelson Purisaca, that I additionally see will give us this view from a very interesting standpoint from this conversation. We'll have a very important view, which is the patient experience with Marta Herrera, and public policy with Aide Rosas, who is here with us in the implementation of Minister Arturo Fernández Ortega, that at the end of the day wasn't able to be here with us, but he will be represented by Aide, and I'm sure she will contribute a lot to this discussion. 3 perspectives, 3 viewpoints that are undoubtedly very complementary in this process. And at the end, let's never forget that behind every data, behind every indicator, there's a person, there's a family, there's a story that deserves to be heard. And that's the invitation for today. Without further ado, I now hand the floor to Oscar. Oscar, please we're ready to listen to the presentation from Wade. I love the data. I think it gives us very relevant information, and it will undoubtedly contribute to all of us down this path. Thank you so much, Diana. It's a pleasure to be here. And today I am going to share a couple of results focused on orphan diseases of the weight indicator study. I invite you to search for the FIFARMA webpage and look for the full report after the webinar, where you will able to find a lot more information at regional level as well as at country level, the 10 countries that we have in this study. This is a very rich study, a broad study that has been developed for 4 years, myself together with a big team of experts in Latin America, using data from IQVIA, and in collaboration also with laboratories in the region, as well as FIFARMA and the local chambers like AMIF, AFIDRO, and others in the region as well. So today, this study and some data of the methodologies before we go into the results. This study contemplates 11 years of innovation. We're talking about molecules that were approved between 2014 and 2024, worldwide, molecules that are already available for populations in Europe, the United States, and other parts in the world, for a total of 403 molecules. We have a sample of 10 countries in Latin America, and you can observe them here at the bottom. And this covers over 80% of the new active substances that have been launched to global markets. This one covers oncology, orphan diseases that are not a part of our other therapeutic areas, that are cardiometabolics, the central nervous system, inflammation, or autoimmune diseases. And a very interesting piece of information is that from our total sample of 400 molecules, 67% are classified as orphan diseases as a first indication. In this study, we anchored the first indication as the spearhead, and what we can see is that there's a lot of research in orphan diseases, which is very positive. However, access and availability is what we are going to be observing the results. This has been slow or deficient in several areas. So we are going to go into the definitions and then the results. This part is very important so that everybody can understand the definitions that I'm going to be talking about along the presentation. First, we have in dark red a definition that is called not approved or not available as well. It's a medication that has not gone through the regulatory process, or that is amid the regulatory process or has not been submitted. Then we have approved, but without a certain degree of access, so non-available. So out-of-pocket is the only option for a patient for these medications. Then we have available only in the private sector, so only privately available through private insurance. That's the only way you can access to this medication, maybe with an insurance payment or with a co-payment. There can be also an out-of-pocket payment that applies. Then limited availability, meaning that there's a restriction, maybe beyond the therapeutical use, or that there are differences in the access between regions, provinces, and states, but that there is a certain degree of reimbursement in the public sector. However, it's not broadly available, as the indication says, or at national level. And then we have full availability, or broad availability means that it's listed in the national forms, it's reimbursed for most of the population. So we researched 4 main questions that we're going to be focusing more on orphan diseases, but also we're going to look at a broader perspective of the entire sample of the weight. Time to availability, how long it takes to become available for the population in the different countries in Latin America. 2, we have availability status, meaning what degree of access does the medication have, or do the medications have. Availability over time, or the evolution of availability time-based. And number 4 is the improvement index. At what improvement rate are we observing the medications, or what level are they improving their level of access? So we're going to observe these metrics and the results given by the study. First, a regional view to contextualize the results. From our sample of 403 molecules, a total of 245, approximately 60%, are approved in at least one country. At least one country. That we're currently seeing that this is very much concentrated in 2 or 3 countries mainly, but they're approved in at least one country. When we see availability, including private and public sector, we have a total of 179, meaning 45% have some sort of availability. And we see when when we are talking about the public sector, only 33% in at least one country are available, either broadly or limitedly. Now we go in time to availability. How long does it take for them to get to markets, to have some degree of access when we're talking about innovative molecules? And in a general way, we have here the average of time from the moment it's approved in the United States or in Europe, the first of 2, and how long does it take to arrive to Latin America on average? And we see in our sample that 38 months is the average in time to availability. Time to get to approval. It can be in delays or in the regulatory process per se. 38 months. It is what it takes to be approved. And this adds 29 months to be available in the country. A total of 5.5 years on average for these medications. When we observe orphan diseases, we can see that in several cases there are delays beyond the average in each country. Notably, Peru, Panama, Dominican Republic, we observe a total delay of over 3 months on average versus our total samples. So in orphan diseases, it can be that there are more delays versus an typical innovative molecule. In no case was there a delay for orphan diseases, regardless of several channels or funds dedicated to some medications in some countries. When we talk about the status of availability, we talk about how long it takes, but to what point does it get to, and how broad is the access? So as we can see, this is a landscape per country. We can see important evidence between the countries in terms of approvals. It could be the red dots and upwards. We can see differences in the type of access that we could have in different countries. Notoriously in Argentina, we have a private sector that's important, that has access to almost 100 molecules, but a public sector with relatively few or little participation of innovative molecules. In contrast, we can see Peru, that generally has a lower number of approvals, lower total access. However, the participation of the public market is greater than the other countries that are on the left. And when we see this landscape and we have a contrast between orphan diseases and the non-orphan diseases, we can see the top and the bottom part, where these differences become clearer. This, once again, is at regional level and talks about the greater degree of access that a new medication has obtained. When we see a broad access for orphan diseases versus non-orphan diseases molecules, we can see that the non-orphan ones reach a higher degree of broad access. The same case or contrast with the molecules that are approved or that don't have a certain degree of access. It can be public or private, meaning they're available only in the sector for out of pocket. So we see that in orphan diseases, there's greater percentage of molecules that don't have any degree of access compared to molecules for non-orphan diseases. This at regional level, and this trend, when we observe it in the different countries, we observe that in most of the countries, this same trend is reflected, meaning there's a lower degree of access relative to the number of molecules for molecules developed for orphan diseases. It's a very clear trend, and it's very pronounced in many of the countries that we have investigated, that we have researched. For some time then, this graph showed at regional level for the entire sample because it shows a point, and it doesn't really change much for orphan diseases. But the general trend is clear. But when we talk about molecules that were approved in 2014, for example, tocilizumab, that has been available over 10 years globally in different countries, the maximum that these molecules reach in Latin America is 53% in at least one country, available at national level, not broadly, while 7% still don't have approval, 10% have approval but still have no access, even public or private, and these are the highest ranges. So this green bar, we can see it coming down, not as a linear trend, but relatively linear, to 2019, pre-pandemic times, where we see a trend that is alarming, which is that for the first time, this drops including public and private sector, to below 50% of the molecules with availability. And when we observe, these molecules are already 5 years old, so they are close to the average in time to access. And we are observing that even though they've had this time in the market, we're still not reaching the degrees of access that we used to have before. So there is a decline in these years in access to molecules. And the opposite is true when we look at the red bars. We see this, the image is taken over by the red bars, which means that there are more and more molecules that don't have either approval, not even in one single country, or that there's no access, even though there is approval. So we see how the red bars come down and the yellow ones come down, so even private sector, and then the red bars start increasing. Finally, the index of improvement. So what percentage of molecules are changing their status year after year? Meaning, how many molecules do we observe from one year to the next that have improved? And what we observed was that between 2024 and 2025, 90% of the molecules stayed halted. They are exactly the same than the previous year. 8% improved, meaning a new approval, or they went from the private sector and they used to be from the private sector and are now available in the public sector, or they used to be approved and not available and now they came into the private sector. 75% of the molecules that were improved were from sequential improvements, meaning private to public, not approved to approved, but not available, etc. And 2% dropped a level. It can be because they were taken out of the market, or they became redundant or obsolete as technologies. Maybe there was a new generation of medication that came in, or the competence forms, it was displaced to another one. So when we think about this at country level, there are important differences. Mexico used to be the country with the greatest number of improvements in last year's study. And this bar up top with the colors indicates if the percentage relative to the sample of orphan diseases or molecules for orphan diseases was higher or lower, corresponding to the total sample. So here we can see a trend that is more positive, and that in several countries, Brazil, Colombia specifically, we saw improvements in orphan diseases that were greater than improvements in non-orphan diseases. However, we have some countries where the trend is the opposite, and we have molecules for non-orphan diseases with a greater advance than those for orphan diseases. So as a summary, the availability of medications, of innovative medications in the region, there's a great variety among countries, there's great gaps to be addressed, and the time to availability is long, and it's a fragmented access route that still has a lot of challenges. The availability status, so most of the patients, meaning in the public sector, they only have access to a fraction of the molecules, and we can see this as an even greater challenge for innovative molecules for orphan diseases. In time, we're observing that we're not reaching the limits that we used to have before, the access levels regionally. However, we do see improvements in some countries, although they are sequential and although it's a slow process in the region. So thank you so much. If there are questions or doubts on the study, I will gladly take them. And I will hand the floor to Carla, Dr. Carla Baez from AMIF. Thank you so much. Thank you so much, Oscar. Undoubtedly great information. The data helps us in decision making. This point is absolutely fundamental for the different guilds related to research and development of molecules. Of course, with very concrete data, this will help us in decision making. And this invites us to talk about today about rare diseases. 8% of the population has a rare disease, 80% from a genetic origin and 20% in non-genetic origin. So it's important, and we have to consider 70% start in infancy. And this is a pleasure. It's a pleasure to have here three panelists that will be sharing different perspectives around the matter on what we're doing and what we can be doing on rare diseases in the region. And I want to introduce Dr. Nelson Burisaca. He is a very well-known geneticist with over 10 years experience in the analysis and the study and attention of medications for rare diseases. Welcome, Nelson. Welcome. Thank you. How are you? Thank you so much. And we also have Marta Herrera, social communicator and journalist in Colombia, the president of the Foundation for Orphan Diseases and executive director of the Colombian Foundation for Lung Cancer, Asthma, EPOC, and other respiratory and oncological diseases. Marta, welcome. It's a pleasure to have you here. And then finally, we have Dr. Aide Rosas Vargas. She is the head of the Medical Research Unit in Human Genetics and the coordinator of the Network of Rare Diseases at the Mexican Institute of Social Security. Welcome, doctor. Good morning. Thank you. Okay, now I would like to start talking a little bit with you to get your perspective so that you can tell us, well, about this odyssey related to the care for rare diseases. And nowadays, our patients have to go through an odyssey to try to get a diagnosis of their disease. But additionally to these obstacles that can exist in the diagnosis, there's also some barriers to be able to effectively access their treatments. Tell us from your perspective, doctor, how long is this delay in the progression to disease and, of course, the impact that this has within the family? Doctor, you're muted. Thank you so much for your question. It's a pleasure to have you all here. Yeah, we have to remember that these patients with rare diseases are highly complex usually. So we are going to have delays in the clinical suspicion of delays to accessing a diagnosis. And here we have the part of treatment. Let's keep in mind that many of these diseases are chronic and they have therapeutic windows that are very strict, meaning a medication that uh, I receive just as soon as I have a diagnosis will probably be better today than in 10 or 15 years when there's probably an irreversible neurological damage. And we have some diseases that are progressing in time. For example, deposit diseases, and in 5 or 10 years, probably my liver will not work, my heart will be severely affected. And other than being able to have access to treatment, it's important to when, because as is being mentioned, there's a several year gap, and this will have a repercussion on the quality of life of the patient. Now, this also definitely addresses the family, and it's a pleasure that you've been mentioning this because now we have to talk about caretakers. Having a diagnosis of a patient with an infrequent or rare disease involves many things. First, years of consultations. These patients or these families start going around looking for answers. It can be symptoms that are apparently very frequent, like a fever or pain that can be the initial presentation of a rare disease. This leads to uncertainty, going to a doctor without being able to get a diagnosis, going to another doctor, there's another diagnosis. So maybe if it were a week or a year, it wouldn't be that bad, but it can be years. And this is a lot of out-of-pocket expenses. There's different opinions, the emotional wear, the uncertainty. The parents in countries like Peru can even have to migrate. If a patient shows up in province where the access to health services are not the best, they don't have the level of specialty that is required for such complex cases. It's a lot of patients that have to migrate, leave their jobs and migrate to where the high specialty services are concentrated, like capitals in this case, and through looking for specialists, and all this makes them develop anxiety or depression, and there's no way to avoid this burden because they're not the ones if they're not the ones to take care of their kids, then who will? So we have the caretaker issues and the burnout, and once we get to the diagnosis and we can access to treatment, we see the barriers that were mentioned, where we know that something exists, but we cannot move forward, and this generates an impact in the family. But this is a vicious cycle that also starts gathering repeated hospitalizations, unnecessary studies, or incorrect treatments, and this is accumulated in time as the years go by, and with a burden for the family that is definitely very, very high, that is severe, and that is very.
Thank you, doctor, very much. So this is a particular case of rare diseases in time really matters. So this is part of the treatment, and that we have to have in timely manner for all these services, and especially for the care of our patients. And this is our mission and our vision, and we really thank you. This will help us understand how to compare these situations in Latin America to other regions, especially in terms of access to treatments and rare diseases, and especially with some experiences that the best practices can bring and that could adapt to the region, of course, to improve the situation.
Bueno, buenos y bendecidos días
Well,
para todos.
a
Muchísimas
blessed
gracias,
day for
Carla, por esta
everyone, and
invitación tan
thank you, Carla, for
maravillosa,
this
podernos
invitation
volver a
and
reencontrar.
for
Bueno, yo te quiero
meeting you
contar que
again. I want to
América
tell you
Latina
that
ha
in Latin
avanzado el
America,
reconocimiento
the
normativo en
recognition of the
muchos
norms
países de
has advanced
Latinoamérica,
in many countries in
incluido
Latin
Colombia,
America,
que fue el
including
pionero,
Colombia, which was
uno
the
de los pioneros
pioneer
después
or one
de
of the
Brasil y
pioneers
Argentina en
after
todo el tema
Brazil and
normativo y
Argentina
de enfermedades
on all
fuertes.
the
Y
regulatory
contamos también
and
con esos
orphan
marcos
diseases.
legales
So
para
we have the
enfermedades
legal
huérfanas
frameworks
y raras,
for
pero seguimos
these rare
teniendo pues una
diseases, and
brecha
we still
bien
have
importante frente a
this
otras
very important
regiones.
gap
A mí me
vis-a-vis
gusta
other
mucho el
regions.
ejercicio de
And
Europa.
I
¿Por
like
qué?
the
Porque ellos
European
tienen
exercise
redes de
because they
referencia y
have
procesos
preference
regulatorios pues más
networks
predecibles,
and the
mecanismos de
regulatory
financiamiento
affairs
específicos que son
that
bien
have the special
interesantes.
financing
Mira,
mechanisms, which
Carla,
are
que en
very
nuestra
interesting.
región el
And in
principal
our
problema
region,
no
the
es la
main problem
ausencia de
is not
intención, porque
the
todos
absence
tenemos la
of
intención
intention.
de
Everyone
visibilizar las
has the good
enfermedades poco
intention of
frecuentes,
envisioning
sino
these rare
en la
diseases, but
fragmentación de
also
la
the
implementación, que es
fragmenting
muy
of the
grave.
implementation,
Y
which is
esto
very
desde la
serious.
perspectiva de nosotros
And
como
this, from
pacientes,
our
¿a qué nos lleva?
perspective,
Cuando hay esa,
leads us
esa
to
falta de voluntad
this
política,
lack
esa
of
falta de la
political
unión
will
de los actores
and
para
union
compartir y no
of
competir,
the
pues nos
actors
lleva
to
a
not
diagnósticos
compete but
tardíos,
to share.
acceso
And this leads
desigual
us
y sobre
to
todo,
tardy
Carla, que estamos
diagnosis
viviendo la mayoría de
and
los países de
especially the load
Latinoamérica,
that
es la
our countries are
judicialización del
living,
acceso.
which is
Todos tenemos
legalization
que
for
mirar cómo
access. We all have
logramos
to
el
see how to
tratamiento no
achieve
por la vía del
this
sistema,
treatment
sino por la
not
vía legal.
by the system
Entonces,
but by the
Carla,
legal
en
means.
América
So, Carla,
Latina, la
in
América
Latin
Latina no
America,
está rezagada en el discurso de
it is
enfermedades
not
poco
lagging
frecuentes,
behind in the
pero sí
discourse
está
and the
rezagada en la
speech, but it
ejecución
is
y en la
in the
voluntad política,
execution
que es
and
muy grave.
political will, which is very serious. Thank you very much for this communication between the different parties, and this will lead to improve in the sense of the access to the treatments with these patients that they're waiting for. So the experiences in all the countries that have helped us to have clarity and to not make mistakes in integral or comprehensive attention and care and disposition, of course, from the vision of our patients. And this is what we're looking for at all times. So here we have the reduction of the times and improvement of the experiences that we have for the patients. I'll be right back with you. And Ade, could you please speak to us from the perspective of the policies that are being established in the different countries, especially in Mexico? What structural flaws have we seen in the health systems that would probably be explaining these gaps in evidence, scientific evidence of the regulation? So, especially the key assessments that are taken in the mid and long term for these experiments to be taken
Sí,
into
muchísimas
account.
gracias, Carla. Bueno, pues voy a
So
hacerle
thank you
eco
very much, Carla. I'm
de
going to
quienes me han
echo
precedido porque creo
on
que tenemos
the
muchas
predecessors
coincidencias,
because I
sobre todo me
think we
voy a
have a lot of
referir
coincidences,
desde una
and I'm going
perspectiva de
to talk
América
from
Latina,
the
no voy
Latin
a tomar el
American
ejemplo de
perspective. I
Europa,
can't
en
take
donde
the
hay un
example of
avance mucho
Europe,
más
where there is a
evidente.
much
Entonces,
evident
bueno, ya lo
base.
dijo
So
Oscar,
Oscar has
claramente
said it clearly.
el tener la aprobación no
Having
significa tener el
approval does
acceso.
not mean you have
Entonces, cuando
access.
estamos hablando de
So when we're
políticas
talking
públicas, tenemos
about
que
public
llegar hasta el
policy,
fondo,
we need
¿no?
to reach the
De toda
bottom
esta
of
problemática.
everything, of the whole
Iniciemos por lo
issues.
que han mencionado
And
ya de las
we've started
dificultades en el
with the
diagnóstico.
difficulties in
Eso
diagnosis.
es algo a lo que se
And this is
enfrenta
something
todavía
that
como
everyone is facing as an odyssey. Most of our patients are doing so. So it's not just in Mexico, also in other countries, we have a health system that is still fragmented, where there is large heterogeneity in the services offered. So we are conscious of this issue, and from each of these institutions, they are structuring strategies to be able to reach out to more people and give them a personal diagnosis, and where they can have the necessary information to receive a follow-up that is adequate. So we know that only 5% of rare diseases have a medical treatment developed and authorized, such that we also have to contemplate other types of approach as regenerative surgery or some sort of training to be able to reintegrate the patients to their regular lives. So the treatment we also see that is not so accessible for everyone, and a large part of this is in the absence of visibility of the patients. We have a very broad territory where these few patients for each disease are distributed throughout the territories, and it's difficult to envision where they are and what their conditions are. So, in addition to this, this medicine is centralized, and it's difficult for these medications to reach the institutions, the health institutions that are outside of the center. So there is a national plan to unify the criteria and creation of follow-up and different points to give this care to the medications and treatments that our patients require. So we are taking actions, and this is an effervescent issue in our country. From the regulatory agencies, COFEPRIS has had a change that allows us to see the improvement that Oscar has given us. And while there is no specific window for the approval of medications, uh, we have reduced the times when the assessment is required, where we can base the evidence from other countries and other organizations such as FDA or EMA. So there's also the possibility to for emergency purchases for ultra rare diseases. So we have a single patient identified in the country, and that doesn't have to go through all of these processes that are so long. And as we've clearly seen with hard data, it's still a reality. So there's still a lot to do, and there's still a will for that. Thank you. Thank you, Aide. And undoubtedly, this is a very important aspect. And we're going to call upon the three panel members so that we can also advance and to tell us what is the message from the clinical part, from the patients, and of course, from the decision makers and the public policy on what we could ask from these decision makers and the regarding the improvements and the patients with rare diseases. So we'd like to know exactly what to expect. So we're all with you
Bueno,
now.
Carla, yo creo que acá
Thank
hay
you,
un mensaje
Carla.
muy importante
There's a very
y
important
es que
message,
los
and
tomadores de
that
decisiones tienen que pensar en cómo
our
se van a generar esos
decision
centros de
makers have to think
referencia
about how
que
to
nos
take those
permitan
reference centers
concentrar el
that allow us to
conocimiento,
concentrate the
mejorar el
knowledge,
diagnóstico y
improve the
optimizar el
diagnosis, and
tratamiento.
optimize the
¿Cómo vamos
treatments.
a lograr hacer
How are
esas
we going
evaluaciones de
to
tecnología en
make
salud
those
adaptadas
assessments
a
and
enfermedades de
adapt them
baja
to
frecuencia?
low
Porque esos
frequency
modelos
diseases? Because
tradicionales de
those models,
costo-efectividad, Carla, no
traditional models
funcionan para
in cost
enfermedades de baja
effectiveness, don't
prevalencia.
work for
Se
these
requieren
low
enfoques
prevalence
más
diseases, and we need
sensibles y lo
more
más
sensitive
importante,
focus
que
and, more
incorporen el valor
importantly,
social
to
y la
incorporate the
equidad.
social value and
¿Cómo vamos a
equity.
lograr esos
How are we
registros
going to
robustos de
achieve those
pacientes? Pues en Colombia tenemos una
registries of
delantera y
those
es que
patients?
en
And
Colombia es de obligatorio
in
reporte de
Colombia,
una
it
enfermedad
is
huérfana que
mandatory
nos
to
ayuda a mejorar
report
la política
an orphan
pública,
disease to
nos
help us
permiten
improve
planificar,
public
financiar y
policy,
evaluar resultados.
plan,
Entonces
financially
necesitamos que esos
assess
tomadores de
results,
decisiones
and we
también
need those
miren
decision
cómo
makers
se van a
also to
generar estos
see how
registros para saber
to
dónde
generate
están,
these
cómo
records to
están,
know
cómo viven.
where they are,
Y esos
how they
modelos de
live.
accesos
And these
innovadores,
access
eso es lo que estamos
models,
trabajando en Colombia
which we are working
desde
on
la
in
sociedad civil,
Colombia,
acuerdos de riesgo compartido, mapas de
uh,
resultados, esquemas
shared risk
diferenciados y sobre todo
differential
buscando esos
schemes, and
recursos para
also
aquellas
looking
nuevas
for
tecnologías que pueden ser
resources
la
for the new
cura de
technologies
muchas
that could be the
enfermedades
cure
huérfanas.
for
Y el
many
mensaje
rare
desde
diseases.
nosotros como
And
organizaciones de
our
pacientes
message
es que
as
todo esto
organizations
funciona si
is that
nosotros
all of
como
this
sociedad civil
works
estamos allí.
with
Porque para nadie
as
es un secreto que a nivel mundial
civil
el
societies. Sorry, so
movimiento de
it's
enfermedades
no
huérfanas se
secret that
mueve
with
es
these
a través de
movements,
nosotros como
uh,
sociedad civil acompañados de otros
so this
actores.
is accompanied by
Muchísimas
other
gracias por la
players.
invitación.
Thank you for the invitation.
Sí. Si algo aprendemos en
So,
genética médica es
if
que la mayor
we've learned
parte de la
anything
familia no
genetically, is that
solamente
the
es la
families
enfermedad, muchas
are
veces
not
es
just
la
concerned about the disease,
incertidumbre
but
del
also the
sistema. Van
uncertainty of the
pasando años
system. So
buscando
there
respuestas, a
are
veces no hay hasta que llegan.
answers,
Y una vez
and
que llegan y se quiere saber qué hacer,
if
empiezan,
they know what to do,
esperemos,
they,
vayamos,
they begin
simplemente
to
no se puede, o
wait
no hay
or decide not to
acceso,
go,
o
or
es
there's no
imposible.
access,
Esas son
or
las
it's
barreras que
impossible.
tiene el paciente.
And
Y creo que tenemos herramientas capaces de cambiar eso.
we have
Estudiando
tools that
sobre
are
fenótipo
able to
temprano
change this
puede
with an
llegar a
early
otro
diagnosis,
camino,
and
puede cambiar las mismas decisiones médicas,
we can
puede
change
hacer que
those
las
medical
familias puedan
decisions and make the
planificar el
families
futuro.
plan the
Y un buen
future.
diagnóstico también nos abre la puerta para
And
un
that opens the
tratamiento. Y
door
no sé, con
for
el
a
tratamiento
treatment.
no
And
solamente es manejar la
remember that with
enfermedad,
treatment, it's
es
not
dar
just
la
about
tranquilidad a la
the illness,
familia,
but
dar
it's also
esperanza,
the
es
peace of
devolverles el
mind of
tiempo
the
que fueron
families.
perdiendo. Así
And
que creo que es fundamental en este
it's
abordaje que damos siempre poner al
fundamental
paciente y su familia al
uh,
centro. Así
for to take
que
the
este tipo de
patient
iniciativas me
first
dan
at the
mucha,
center.
mucha
So
ilusión y
this type
espero
of
que siga
initiatives
avanzando
gives
el
me
acceso en
a
nuestra
lot of
región.
faith, and we hope that this progress is still advancing very well. Yes, undoubtedly, we're going to have to advance towards that. And
Sí, bueno,
Doctor,
creo que
please,
es muy
Dr.
importante la
Rosas.
estructuración de un
Yes,
plan
the
nacional
structure of
sin
a
dejar
national
de
plan
lado
is
la
very
cooperación
important.
internacional.
And
Es muy importante
without leaving
pensar en
aside
los centros de
international
referencia que
cooperation, we need to
Romata,
think
pero
of
también
the reference
es
centers.
una
But
realidad que no se puede cubrir en cada uno de estos
this is a
centros de
reality that we can't
referencia
cover
las
in each
siete
of our
mil
reference centers,
enfermedades
the
y vale
7,000
la pena
illnesses
optimizar
or
recursos
diseases. And
por grupo de enfermedades con
so we need to
especialistas en cada
make
una
these
de ellas.
specialist
¿Y por
groups in
qué
each one of
no
them.
cooperando
And
entre los
why not
países?
cooperating between the
Dentro
countries?
de estos
So
planes o este plan nacional debe estar incluido, por
this
supuesto,
national
un
plan has to be
registro
included, of
que
course,
sea
with a
interoperable
registry
y
that is
dinámico para
interoperable
poder
and
ir
dynamic
adaptando a
to
las
be
nuevas
able
necesidades del país y,
to
por
adapt to
supuesto,
the
de
new
los
needs of the
pacientes.
country and
Y
especially the patients. So
pensando siempre en la
thinking
equidad, en la
always of
homologación en
equity
nuestro
and the
sistema de salud
standardization of our health
y,
system.
por supuesto, debe
And
de existir en cada país un apartado
there should
financiero
be a
fijo y
financial
específico para las enfermedades
budget
raras y
for
todos los
these
requerimientos
rare
que se tengan
diseases
al
and
respecto.
all the requirements that they have.
Gracias.
Thank you very much. So
Claro que sí.
now,
Mira
if we
que
can
con
have
referencia a lo que dice la doctora Aide de los
Dr. Herrera,
programas de
yes.
referencia,
What the
no
doctor's saying
es
is
que
true in the reference
existan
programs. It's not that
7.000 programas
there's
de referencia, sino que se
7,000
pueda,
reference
como está
programs,
haciendo
but
Colombia,
that as Colombia is doing,
uniendo por condiciones
uh, there
neurológica,
are
de la
conditions
sangre,
that are being
oculares y
united,
poder generar
blood and
buenos
others,
programas de
and to
referencia en las
generate
ciudades
good reference
principales
programs in the
con
main
la idea de
cities
hospitales
with the
hermanos.
idea
Entonces, si el
of
paciente viene de
sibling
una
hospitals.
región
So if the
lejana, allí hay
patient is
unas
coming from a
EPS o
faraway
hospitales que los
region,
atienden, pero hay un centro de
then
referencia grande
there
que le
are
ayuda
some
a este
centers of
hospital hermano
references
a
that
tratar
help
y llevar la
these
continuidad. Entonces
and
salen del
to have
programa de
continuity. So
referencia
they come out of
con
their
todas
reference
sus
program
indicaciones
with all of their
y en su
indications
región
and
los
in their
van
regions,
atendiendo, les van
and they're
haciendo
going to be
seguimiento y
served
yo creo que
and
hay algo
followed
muy
up on.
importante.
And it's
Si
very
logramos
important
crear un
if
sistema de
we
salud que
can create
funcione
a
para
health
las
system
enfermedades
that works
huérfanas, este
for the
sistema de
rare
salud le va a
diseases. That
funcionar a
system
todas las
will
enfermedades,
help
independiente de la
for
que sea.
all the
Pero el
diseases,
tema de los
regardless what
programas
they
de
are.
referencia
But
nos
reference
ayudan a mejorar
programs
la calidad y cantidad
help
de vida.
us to regulate the quality of life. And I say it because of the reference program we have in Colombia in cystic fibrosis. My niece before was hospitalized between 7 or 8 times a year before the reference program. With this reference program, which is 11 years old for cystic fibrosis, it's been 2 or 3 times a year. And she's off the transplant list and has access to new technologies. So with these reference programs, we can earn a lot, and this follow-up for our families and for our pockets is very good. Thank you very much, Martha, Natalia. Or the idea, ladies and gentlemen, is that this topic of rare diseases invites us to innovate, to search for new alternatives, and to create everything that can improve the lives of our patients. And so this is extraordinary, and we're very grateful for this invitation again to innovate in acquisition processes, innovate in, of course, accompaniment for our patients, for the families, for the caregivers, but also, of course, in the development of the different instruments in public policy, national, domestic campaigns that could be given in our countries, considering, of course, all of the specificities of each one of those in their regions, but also the intercommunication that has been mentioned by Aide, and of course, Dr. Bisaka has mentioned it to involve everyone in this diagnosis and to have access, timely access for the requirements in the patients and treatments where they should be integrated at all times, not just in rare diseases, but also the entirety of health ailments with an integral treatment that helps us to give this primary care and the incorporation of our patients into their financial and social lives. So this is something that we have to remember for the success of the different decisions that are made in every pathology. So, two final messages. Time does matter in health, undoubtedly, and we're trying to not leave this behind. This has to be absolutely equitable, and we're going that way with the innovation process. And this will close the forum. And we hand over to a colleague of ours, and Catalina Bello, the Director of Access of AFIDRO, for the final messages and the closing of this panel, which also we coincide and we're happy and enthusiastic to have from this standpoint. Hello, Carla. Thank you to these 3 dimensions and visions of a program that we need to address as a team. Carla's invitation is to innovate, and we have to innovate working together. So it's important to remember that this is a joint task. It's part of the industry that has to continue guaranteeing medication and treatments to answer to the challenges that many patients have, and in our region as well, with these diseases. And we need to have therapeutic answers and innovate in these pathologies. And we also need to have, as health systems, timely answers for the patients that have to go through many ordeals and challenges in the health systems. But it's important that this is not just a government's challenge, it's of every agent that's in the health systems, all the ecosystems in health. We need to have early diagnosis for the patients, and this has to be part of a patients with timely care, have access to treatments, and information has been given that is concerning about these treatments in the region so quickly as we would like. But it's not just about approving the treatments or having a health registry, but it also has to have the financial protection of the families and the patients with rare diseases. So Sometimes they are not covered by families, and it's important that the health system have an answer in that financial dimension so that the families can have access in timely manner and treatment that can improve their quality of life. And with the panel members, we thank them for joining us today. The patient is a person that has other types of needs, and that's why the governments have to work in articulation to have an answer and to have education. And for this, integration is not just from the disease, but as a citizen of a country that needs to have answers. So this is an invitation for this not to be just a task of the health systems, but also the integration of a government that needs to have an answer for these patients. So it's important, and to close, as Martha said, it's intentional, and we need to work on this intention being completed in several ways: timely access to technology and availability of the product, and to have that option in your country, but also to have financial availability. So this is happening in Colombia, and we have a health system that Martha pointed out offers special protections for the patients with orphan diseases, and this special protection has to happen in assistance and financial responsibility, and this has a health registry, and it has to not put its financial situation at risk for the patient. So this has to be articulated work, and the people in this region have to work in unison to care for these patients with these rare diseases.
Muchas gracias a todos por conectarse. Gracias por estar aquí en este
Thank
webinar
you,
y con esto
everyone,
ya
for
damos por
being here on this
finalizado este
webinar,
webinar del
and
día de
this
hoy.
closes
Gracias a todos.
today's event. Thank you, everyone.